Okay, madam.
Okay.
Yeah.
6 o'clock, 3 minutes, Nilesh.
Yeah.
Yes, ma'am. I'm making the
Yeah.
session live.
Yeah. I'm just telling you.
So we are live now.
Okay, please start the program.
Good evening to all the committee members and delegates who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this Happy Learning Masterclass webinar, 179th edition, in association with Bidar, Chitradur, Davangere, Gadak, and Raichur. The theme for today's webinar is mixed bag. The convener for today's webinar is Dr. Asha Jain. Let me introduce Madam. Madam Asha Jain has 32 years of vast experience. Madam has Foxy Register Ultrasound Training Center and Colposcopy Training Center. Currently, Madam is Director SMSA Hospital Raipur, Medical Director Cancer Prevention and Relief Society, elected member of Chhattisgarh Medical Counseling, and Madam's fields of interest are saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, and preventing oncology and colposcopy. So I welcome you, Madam. And as per the tradition, host, we will start our session with lamp lightning test. Thank you so much, all respected doctors. Now I have the session to Dr. Ajay. So over to you, madam.
Yeah, please display this. Please display the CVs of Rekha ma'am and Bharti ma'am. Namaskar.
Yes,
On behalf of Happy Masterclass and Dr. MC Patel sir, I welcome all respected faculty and delegates to this webinar. As Dr. MC Patel sir is caught up in a case, he will be joining shortly. Meanwhile, I will introduce our two coordinators and they will both give a short welcome address. So both the coordinators are very well known to this forum. Dr. Rekha Rajendra Kumar ma'am, who is a practicing gynecologist for 32 years. She is the incoming president of Bangalore Obstetric Gynec Society, has a lot of academic work behind her. She's currently the chairperson of Ethics and Medical Legal Committee, Kasoga, chairperson Infertility and ART Committee, Kasoga, before this, and South Zone coordinator of Foxy Infertility Committee 2021 to 23. She is also the founder, EC member, KIFS 2019 to 13. She has many awards and felicitations. She is a dear friend and also a great dancer. So, may I have Dr. Bharti, please? Dr. Bharti's CV. We also have Dr. Bharti Rajshekhar with us, who's the medical director and obstetric gynec consultant at Vatsalya Hospital, Hassan. She is the president-elect Kasoga and will be taking over in April. She is the KPMEA state vice president. She has a lot of kudos which you all know about. She is also a dear friend working very actively in women's health and is going for chairperson perinatology committee this year. And all the presidents and secretaries present here are requested to support her. So welcome, Dr. Rekha. And Dr. Bharti, I would like you to welcome the gathering with a few words. Please stop sharing. Over to you, Dr. Rekha.
Yeah. Nilesh, can I have, we will take sir's wordings and blessings once he joins. Till then, I will keep the program going. I request Nilesh to show me the CV of guest of honor, that is
No,
Dr.
please, Dr. Rekha, you have to
Welcome,
welcome everyone first.
welcome.
You have done that, no? Yeah.
No, I haven't done it.
Okay, I thought you. Okay, sorry. Yeah, thank you, Dr. Asha. Happy to be the convener and coordinator of this program with Sir since long time. And here we welcome all of you, the seniors, Dr. Jambunatha Gowda sir as a guest of honor, Dr. Virendra Kumar again as guest of honor. Thank you, sir, for being present here. And my dear friend and mentor, Dr. Shukla Shetty madam. Madam agreed without any hesitation to grace the occasion as the chief guest. Thank you, madam, for your honorable and esteemed presence here. And we also welcome the chairpersons of the first talk, my close friend, Dr. Shailaja Bidri, Dr. Suman Gaddi, madam is the treasurer of Kasoga, and Dr. Lalitama, madam, who is the senior consultant of OBG. I hereby also welcome Dr. Shobha Dhananjaya, who is the speaker in today's program. Dr. Shobha madam is going to speak on RH negative pregnancy, the current concepts. This is the first part of our program. After that, we have Dr. MC Patel sir, who will take the panel. I welcome the panelists, Dr. Shivkumar HC, Dr. Pranita Ajay, Dr. Uma Deshmukh madam, Dr. Rameshwari Malshetty, Dr. Jyoti Sharat Kumar from Chitradurga, Dr. Rashmi as secretary, Dr. Rashmi Shetty could not join, unfortunately, because of her ill health today. Dr. Vijay Kumar, Dr. Shruti Bhavi Patil from Gadag, Dr. Annapurna Danur again from Gadag, Dr. Mangala Gadwal Madam, Dr. Harsha from Davangere, and Dr. Abhinetri Patil. I hereby welcome all of you. Thank you so much for accepting our invitation and joining this program. I'm sure that you will be much wiser at the end of this program. Thank you one and all for being here.
Dr. Bharti, you're requested to say a few words.
Sure. Thank you, Dr. Asha. And I extend a very warm welcome to all my dear Kasogians who are all our dear friends over here. And Dr. Rekha has already personally named all of you. I thank all of you for being with us here on this important Happy Learning webinar. And I would like to express our gratitude and also appeal for Dr. MC Patel, who will be going for the presidential elections in August. Dr. Asha Jain will be going for the Food, Drug and Medico-Surgical Committee as chairperson, and myself will be going for the Perinatology Committee. And I know all of you have always been with us. We request you to always stick on with us and see that we do have a say in the FOGSI managing committee so that we can work for the betterment of women as well as for the betterment of the FOGSians. So I extend a warm welcome for you, to all of you. And I now request Dr. Rekha to take the program forward without wasting much time. Thank you, Dr. Asha, for the opportunity.
Thank you, Dr. Bharti. Nilesh ji, would you please share Dr. Shukla ma'am's CV?
Meanwhile, I request all of you to support Dr. MC Patel sir, Dr. Bharti Rajshekar, and Dr. Asha Jain for their respective posts. Thank you.
Thank you so much, Dr. Rekha.
Yeah.
So it is a pleasure and a privilege to introduce Dr. Shukla Shetty ma'am, who is the mentor of Dr. Rekha. So she's the professor and head of the Department of Obstetrics and Gynecology, JJM Medical College, Davangere. She's an alumni of JJMMC. She has 30 years of teaching experience, and she's interested in critical care and high-risk pregnancy. I think this is a really short CV that she has made, and there must be pages upon pages that could be written about her. But over to you, ma'am, for your words of wisdom and blessings to this webinar.
Thank you, Dr. Asha Jain, for the wonderful introduction you have given me. And I thank Dr. MC Patel for giving me this chance to be the chief guest. Last time I was one of the panel member for preterm labor, and this time have been called as a chief guest. It's a real pleasure to be in this part of the webinar. It's almost 179th, so it's something more than 3.5 years of every Tuesday's work. Almost all Dr. M.C. Patel has seen that like all the chapters of both obstetrics, gynec, infertility, everything is covered. Along with that, the legal aspects also of those portions are being covered every week. And it's, even at this, I mean, his enthusiasm is really contagious. His words of wisdom on everything, like even a forceps or a prolonged labor or on partogram or on infertility, every detailed thing is being discussed whenever he talks on Tuesday on the legal aspects. So it's a real pleasure to be with the Happy Learning thing. And one more thing is, I think I wish him, he's a apt candidate for being the president of the FOGSI, which is the pillar of our nation, which takes us forward. I think it is long due. I think he should have been the president long back. That's what I feel. And I wish him all the best. And let me be very sincere in this one, Rekha's, she is the thread between for us connecting for Karnataka. She is the one who coordinates 1 month ahead, asks us everything. I kudos to you, Rekha, with all your busy schedule of infertility and everything. You are linking all of us to this great seminar, and I really thank you for making us. I think there are a lot of people from Davangere society, and almost like it looks like the whole Karnataka people are almost, I mean, this is the south portion where we are all there. She has really done a wonderful job, and Dr. Bharti and we are almost colleagues. So it's nice to interact with you, and I hope this thing goes on and gives a lot of information, not only on the topics, but also the legal aspects, as Dr. Patel every week discusses for a long forward, because as practicing people, we don't know much of it, or even being in the college, we don't know much of the legal aspects, what gets covered. I think it is happy learning, and thank you again for having given me this chance to be the guest of honor. Thank you.
Thank you, ma'am. Thanks a lot. And please bless me as well. I'll be going for chairperson.
Yes, ma'am. Sorry, I just forgot. You also need it. Yeah, you're from Raipur. You have done wonderful job. All the best for your getting elected for the post what you're taking. Yeah, thank you.
Over to you, Dr. Rekha. Nilesh ji, please display the CVs.
Thank you, Shukla madam, for such nice words. We feel so happy for all this. Thank you for recognizing our efforts. It's my proud privilege once again and a pleasure moment to introduce none other than very senior obstetrician gynecologist, that is Dr. Jambunath Gowda. Sir is MBBS MD obstetrician and gynecologist complete. He has received ultrasound and IUI training way back from Mumbai and Kerala. Sir is an infertility specialist also, life member of big bodies like FOGSI, ISAR and IIGE. He has done lots of camps and conducted lot of women awareness programs. Also, sir has won many number of awards, and he's conducted state level Muscon ultrasound conference in Gangavati around 2 decades ago. Thank you, sir, for being here, and we would like to hear from you. Sir, you are muted. Please unmute yourself and bless us, sir. Sir, you have muted yourself.
Jambunath sir, unmute Madi. No, sir, you are muted.
Yeah.
Yeah.
Oh, thank you, Patel sir, for having called me for guest of honor for this 179th continuous program for these legal aspects every Tuesday. Actually, almost we have attended so many this one, and we were very much enlightened by our legal aspects. And thank you very much once again, and I wish you all the best for the program. Thank you.
Thank you so much, Jambunath sir. Can I invite Dr. Virendra Kumar CM sir from Bellary Obstetric Gynecology Society, a senior obstetrician gynecologist, and I request Nilesh to display sir's CV. Yeah, thank you so much, Mr. Nilesh. Welcome, Dr. Virendra Kumar sir.
Thank you, madam.
He's a pioneer in Bellary Obstetric Gynec Society, and we remember your hospitality when you conducted the Kasoga in Bellary. Sir is a professor and head of the Department of Obstetric Gynecology from BIMS Bellary, president around 3-4 years back of Bellary Society, also the secretary of Bellary Society and IMA Bellary, chief coordinator for Wisdom PGCME. Sir has very rich academic accomplishments. His CV is very rich. Thank you, sir, for being here, and please advise us and take us forward. Thank you, sir.
Thank you. Good evening, all. Thank you, madam, for inviting me as a guest of honor. And I am amazed at the energy level of Dr. Rekha Rajendra Kumar and Dr. MC Patel in organizing such an important program. And really, with the happy learning program on every Tuesday, a lot of our members have been enriched with a lot of wisdom and experience. I really congratulate Dr. Rekha Rajendra Kumar and Dr. MC Patel for organizing such program. I wish all the best for this program, and we love to see MC Patel in future as president of FOGSI, who richly deserve this post. Thank you, sir.
Thank you so much, sir. I'm sure you also have blessed our other two contestants, Dr. Bharti Rajshekar for
Yes, ma'am. Yes, definitely.
Asha Jain for the Food and Drug Committee. Thank you so much, sir. I have requested on their behalf. Thank you. We move forward now. Now we are into the academic session. I request three chairpersons, Dr. Shailaja Bidri, Dr. Suman Gaddi, and Dr. Lalitama, to chair the session. Mr. Nilesh, I would like to have the CV of all these three. Shailaja Bidri madam is a very senior obstetrician gynecologist. Madam is also the North Zone EC member of Kasoga. We remember the hospitality, what she had provided us. It was of very class treatment, what we received recently in Kasoga, Bijapur. Madam is a professor and head of the Department of Obstetrics Gynecology. BLD Shri BM Medical College Hospital and Research Center is where she is working. As I have said, she is the EC member of North Zone, lot of academics, publications, and madam has conducted lot of public awareness programs on women's health, especially on postpartum hemorrhage and menstrual hygiene. Madam has also conducted lots of camps on cervical cytology screening. Thank you, madam. We would like to hear from you. Shailaja, madam, over to you.
Thank you, madam. Thank you for your nice introduction.
Yeah. Madam, after I introduce the other two chairpersons, I request you to introduce the speaker, that is Shobha
Okay,
Now I introduce another chairperson, that is Dr. Suman Gaddi, madam. Madam is the treasurer of Kasoga, former professor and head of the Department of WIMS Bellary. She has a rich teaching experience, close to 3 decades. Kasoga EC member before she was the treasurer. She was also the organizing chairperson of Kasoga, which was held in Bellary. And she has a lot of publications, and her area of interest is preventive oncology and high-risk pregnancy. Kudos to you, madam. We request you to chair the session as well as tell few words about the topic. Now, Mr. Nilesh, I would like to have the CV of Dr. Lalitama. Madam is the third chairperson we have here. Thank you, Mr. Nilesh. Dr. Lalitama is madam is a MBBS DGO MD from Davangere. She is senior obstetrician gynecologist and program officer of health and family welfare of Bidar, founder secretary of Bidar Obstetrics Gynecologic Society, as well as the past president, and she was also the vice president of IMA. Madam is the chairperson of Kasoga and AICOG. Madam, over to you. Madam Lalitama, I request you to, at the end of the topic, after Dr. Shobha Dhananjaya, I request you to conclude the talk and give your some important take-home points. Thank you to chairpersons, and over to you to introduce Dr. Shobha Dhananjaya and take the program forward. Thank you, one and all. Shailaja madam.
Yes. Good evening, everybody. It is my pleasure or honor to introduce Dr. Shobha Dhananjay. She is MBBS MD DGO, Professor and Unit Head of Department of OBG, JJM Medical College, Davangere, and Chairperson of Prevention of Violence Against Women Committee, Kasoga, President of OBG Society, Davangere since 8 years, UG and PG teacher since 25 years at JJMC, PG guide since 20 years, examiner for UG, PG at various universities, presented papers at state and national level conferences, president of Innerview Club of a social organization for 3 years. Over to you, Madam Shobha, Madam.
Dr. Suman Gaddi, please tell few words about the topic and then Dr. Shobha will start.
Sure.
Meanwhile, she'll be sharing her screen.
Yes.
Yeah, good evening to one and all. Of course, this topic for today, the RH negative pregnancy, current aspects will, of course, help us in day-to-day practice, and it is quite an important topic as it is a high-risk pregnancy, and one should, of course, know at least how to move forward with these cases. And I'm sure Dr. Shobha Dhananjay will highlight on this topic, and at the end of the talk, we'll have a little discussion. Thank you.
Thank you, ma'am. Shall I start, ma'am?
Yes.
Yeah.
Please start.
Okay. Good evening, everybody. So at the outset, I thank Dr. MC Patel sir and Rekha ma'am for giving me an opportunity to participate in this webinar, and also Shailaja Bidri madam to introduce her nice words. So I'll go ahead with my topic, RH negative pregnancy current aspects. As such, the heading says current aspects. Recently, there is not much change, but it's sort of old wine in a new bottle. So I just wanted to convey some of the guidelines regarding the ACOG and ICOG guidelines about the RH negative pregnancy management during antenatal as well as postpartum. It's a condition in which the red cells of the fetus or newborn are destroyed by the maternally derived alloantibodies. The antibodies arise in the mother as the direct result of blood group incompatibility between the mother and the fetus, as all of us know. The mother becomes isoimmunized. In the fetus, it causes erythroblastosis fetalis, and in the newborn, the hemolytic disease of the newborn. So RH negative frequencies in population says, in Indian, it is only less, that is 5%, whereas African Americans constitutes about 7 to 8%, and Caucasians are the maximum, about 15%. So that is the pathophysiology to come to that. Alloimmunization, also called isoimmunization, has been defined as an immune response generalized in an individual of one species by an alloantigen from a different individual of the same species, which the recipient lacks. Here, all of us see there is a RH positive father with the RH negative mother carrying her first RH positive fetus. RH antigens from the developing fetus can enter the mother's blood during delivery. Then in response to the fetal RH antigens, the mother will produce anti-RH antibodies. If the woman becomes pregnant with another RH positive fetus, that is the second pregnancy, her anti-RH antibodies will cross the placenta and damage the fetal red cells. This is a basic theory, what all of us know. In the first pregnancy, the IgM antibodies are formed and are unable to enter the placenta. By the time IgG antibody arrive, the first child would be delivered. So these IgM antibodies will not cross the placenta, thereby the first child has already been delivered. That means it starts from 6 weeks to 6 months to form the IgG. So IgM will not cross. So by the time IgG forms, the first delivery already happens. So in the second pregnancy, even a small amount of antigen is enough to initiate a response, and the secondary response comprises IgG, which can cross the placental barrier. So as there is a secondary response to the mother, and IgG will cross the placenta and causes hemolysis and causes fetal anemia. Currently, the rate of against Rh negative mother is approximately about 1.6 to 1.9%. By giving additional third trimester prophylaxis, 0.2%. The incidence of fetal-maternal hemorrhage is high in each of the trimesters. So that is, in the first trimester, it is only about 56%, second in 63%, and in third trimester, it is about 71%. But as all of us know, as little as 0.01 ml, a very tiny ml of blood is sufficient for sensitization to occur. The other factors influencing the probability of primary alloimmunization as factors influencing the probability of primary alloimmunization are size of the inoculum, as I said, coexistence of ABO incompatibility between the mother and the fetus, and the very important, what we all see in our wards, a multigravidas, though they are delivering a Rh positive mother, they will not be immunized. About 30 to 35% of Rh negative subjects are non-responders. That is what we have to keep in mind, because second gravida, third gravida, though they are not immunized in the previous pregnancies, nothing will happen to the mother, so that they keep on delivering. So cannot immunize to Rh positive antigen. Antepartum events contribute to alloimmunization is about 1 to 2% of the woman. The antepartum events associated with fetal-maternal hemorrhage are as follows. That is, first and second trimester miscarriages, ectopic pregnancy, fetal death after 10 weeks, CVS and amniocentesis, that is the invasive procedures, ECV, bleeding from placenta previa and abruption, abdominal trauma. The incidence of FMH is high in each of the trimester, as already mentioned, in first, second, third trimesters respectively, and as little as 0.01 ml is sufficient for sensitization to occur. Fetal blood group can be confirmed as early as 9 weeks of gestation by obtaining trophoblast by CVS, or at 16 weeks by aminocytes obtained by amniocentesis. Fetal DNA in the maternal peripheral blood to provide non-invasive methods of diagnosing fetal blood group. Fetal RHD genotype can now be determined from analysis by circulating cell-free fetal DNA in maternal plasma. Right now, this procedure is going on. Diagnosis of maternal isoimmunization. This contributes antibody titer in the saline, that is Rh positive cells suspended in saline solution or agglutinated by IgM or recent antibody production. Antibody titer in albumin reflects the presence of any anti-D IgG antibody in the maternal serum, the indirect Coombs test. This is the indirect Coombs test, where the recipient's serum is obtained containing the antibodies. Donor's blood sample is added to the tube with serum. Then comes the recipient's antibodies that target the donor red blood cells from the antibody antigen complexes. Then anti-human antibodies are added to the solution. Then coming to agglutination of red blood cells occurs because human antibodies are attached to the red blood cells. That is, the positive test results happens. This is the pictorial representation of indirect Coombs test, what we are routinely performing in our antenatal woman around 28 weeks of gestation. Estimation of fetal-maternal hemorrhage. Quantitative assessment of FMH helps to determine the dose of anti-D immunoglobulin is needed. The Kleher-Betke test is the most commonly employed test to estimate the size of FMH. This is how it looks under the microscope. That is the fetal RBCs and maternal RBCs, and weak positive fetal RBCs are seen under the peripheral smear. Fetal-maternal hemorrhage. There is about 50 to 75% of the pregnancies, there is very small amount of fetal-maternal hemorrhage. That is about 0.01 to 0.1 cc. The clinical signs for the severe, then only we can make out how much of the fetal hemorrhage occurs is where there is decreased fetal movement, sinusoidal fetal heart pattern, and pallor, tachypnea. All these are the signs to say that there is fetal-maternal hemorrhage. Kleher-Betke detects fetal blood in maternal blood. Treat with citric acid phosphate buffer, that is pH at about 3.3. Adult hemoglobin dissolves the ghost-like cells. Fetal hemoglobin stains red. That is, percentage of fetal hemoglobin is equal to fetal cells versus maternal cells multiplied by 100. That is, 1% of hemoglobin, fetal hemoglobin is equal to 50 ml of fetal blood. Then when do we call it as critical titer? The critical titer is one at which there is significant risk of fetal hydrops. It is typically between 1 in 8 and 1 in 32 dilutions, which varies in different laboratories. The antibody titers is expressed as a reciprocal of the highest dilution of serum that causes agglutination. The first affected Rh immunized pregnancy generally shows a better correlation with the titers compared to subsequently affected pregnancies. These are potential sensitizing events are in the antepartum, postpartum, and the intrapartum and postpartum. All of us know about the miscarriages, and the evacuation of retained products of conception do causes fetal-maternal hemorrhage, ectopic pregnancy, obstetric procedures as already mentioned, amniocentesis, CVS, ECV, fetal blood sampling, in utero blood transfusion, abdominal trauma, and fetal-maternal hemorrhage. Intrapartum are some of the instrumental deliveries like forceps and vacuum, cesarean sections, stillbirths, placental abruption and MRP, and postpartum are blood transfusions. Role of Doppler in Rh negative mother. There is fall in fetal hemoglobin, resulting in increased cardiac output, decreased blood viscosity, and increased maximum systolic flow velocity. A peak systolic velocity of blood flow in the middle cerebral artery above 1.5 multiples of median for gestational age detects moderate to severe anemia. At least 3 values of MCA Doppler should be taken prior to confirming the fetal anemia. This is the non-invasive, and it is at present all the fetal medicine specialists are doing MCA Doppler, that is the peak systolic velocity, instead of invasive procedures like CVS and amniocentesis. Coming to invasive test, amniocentesis was carried out from 18 to 20 weeks onwards, depending on the history or antibody titers. To determine the level of bilirubin and bilirubinoid substances in the amniotic fluid by spectrophotometry that contribute to the optical density absorption peak at 450 nanometer. Previously affected fetus or neonate, that is referred to a perinatal center and assess the zygosity of paternal phenotype. If he is homozygous, manage as an isoimmunized pregnancy. If he is an heterozygous, fetal Rh status by cell-free fetal DNA or amniocentesis at 15 weeks. Fetal blood transfusion. The indications of fetal blood transfusion are as follows. Evidence of fetal hydrops on ultrasound, elevated peak middle cerebral artery Doppler velocity if it is more than 1.5 multiples of median, elevation of optical density 450 values, that is 80th percentile of zone 2 or zone 3 on Lilly's curve, which I am going to show in my next slides. Yeah, this is the Lilly's curve. The deviation of baseline optical density. This is the baseline optical density. There is a deviation of optical density curve at 450 nm due to amniotic fluid bilirubin level. Optical density of amniotic fluid is 1, which corresponds to very high zone, that is zone 3 on Lilly's chart. The fetal serum bilirubin level mirrors that the amniotic fluid. Here in the zone 3, if it falls on zone 3, definitely intrauterine transfusion should be done at around 30 to 34 weeks of gestation, and delivery should be taken place at 35 weeks, and later on exchange transfusion in the perinatal period. Intrauterine fetal blood transfusion. By the early 1980s, intrauterine intraperitoneal blood transfusion was firmly established as a treatment for fetuses identified by amniotic fluid optical density 450, estimated as being severely affected, but who were too immature to be delivered, that is less than 32 to 34 weeks. Ultrasound guided techniques have since replaced the need for fetoscopy. What are the sites for transfusion? Umbilical cord, usually into the umbilical vein, either at the site where the cord inserts into the placenta, or baby's liver or free loop of cord. Peritoneal cavity, that is intraperitoneal transfusion. Baby's liver, that is intrahepatic. Baby's heart or intracardiac transfusion. Intrauterine fetal blood transfusion is undertaken for fetus with gestational age less than 34 weeks if fetal hemoglobin is less than 9 grams and or hematocrit is less than 30%. Intravascular transfusion, that is the umbilical vein at the placental insertion, is the most commonly used site. A 20-gauge spinal needle is passed into the umbilical vein and 1 ml of fetal blood is aspirated. The fetal blood sample is immediately assessed for hematocrit, and if it is below 30%, intravascular transfusion is given at the same setting. At the end of the procedure, the final sample of fetal blood is taken to estimate the post-transfusion fetal hematocrit. The blood used for transfusion is adult group O negative, that is Rh negative. It should be fresh, not more than 72 hours old, and cross-matched against the mother's blood. It should also have been screened for hepatitis B and C, cytomegalovirus and HIV, as well as irradiated to remove the white blood cells to avoid graft versus host-like complications in the fetus. The blood is packed to a hematocrit of 75 to 85%. The volume of blood to be transfused is determined by 3 parameters. The first is pre-transfusion fetal hematocrit, as I already mentioned, estimated feto-placental blood volume, the hematocrit of the donor blood. Coming to intraperitoneal transfusion, donor blood is transfused into the peritoneal cavity, where it is absorbed over a period of time via the fetal subdiaphragmatic lymphatics and thoracic ducts. The indications are as follows. Below 18 weeks gestation, when the umbilical vein is too small for safe venipuncture, thereby intraperitoneal transfusion is performed. Difficult to gain venous access due to the fetus lying with its spine anteriorly. Volume of blood to be transfused is calculated as gestational age in weeks minus 20 multiplied by 10. The quantity of blood transfused is in intraperitoneal transfusion is related to the gestational age of the fetus rather than the degree of anemia. Follow-up after fetal transfusion. Fetal surveillance following fetal blood transfusion is done by monitoring fetal heart by cardiotocography for about an hour after the procedure. The mother is advised to count daily fetal movements and attend antenatal clinic 1 to 2 weeks for ultrasound evaluation of MCA Doppler peak systolic value, umbilical artery flow velocimetry, and any evidence of compromise. Coming to short-term outcomes, the overall survival exceeding 80%. Non-hydropic fetuses with survival rates more than 90% compared to those with hydrops is about 70%. Long-term outcome are the incidence of neurodevelopmental impairment in children treated with intrauterine transfusions for fetal alloimmune anemia was reported low. According to the Lotus study, it is only about 4.8% in a series of 291 infants followed up to 8 years. Complications of intrauterine blood transfusions are emergency delivery and result in preterm birth, preterm pre-labor rupture of membrane, infections like chorioamnionitis, preterm labor and fetal distress. Further antibody formation in the mother, increasing antibody sensation and further exacerbating the fetal hemolytic process, suppressing the baby's ability to produce its own red blood cells. Immunoglobulin therapy. If intravenous immunoglobulin therapy is considered, it should be started at 9 to 10 weeks. The recommended dose begin 1 gram per kg maternal body weight at weekly intervals. It delays the need for transfusion until 22 to 24 weeks of gestation. Yes, the important what I wanted to convey the guidelines. So according to ACOG, the following recommendations are based on good and consistent scientific evidence. That is level A says that unsensitized Rh negative woman should be offered prophylactic anti-D immune, that is within 72 hours of delivery if the infant is confirmed to be Rh positive. Level B evidence says Rh immunoglobulin is recommended for all invasive diagnostic procedures like CVS, amniocentesis in Rh negative woman with Rh positive fetus. The following recommendations are based on good and consistent scientific evidence. The anti-D immunoglobulin prophylaxis should be considered for all Rh negative women like threatened abortion, uterine evacuation, second and third trimester antenatal bleeding, ECV, abdominal trauma, pregnancy termination either medical or surgical, ectopic pregnancy, antenatal hemorrhage after 20 weeks of gestation, or molar pregnancy. This is the dose recommended by ACOG, like incomplete miscarriage, 150 microgram, first 12 weeks of gestation. Spontaneous complete miscarriage does not require anti-D because no manipulation is done. MTPs like surgical evacuation, again 150 to 300 microgram depending on the gestational age. Ruptured tubal ectopic pregnancy, obviously it will be less than 12 weeks, so 150 microgram. CVS procedure, again 150 microgram before 12 weeks. Amniocentesis 150 to 300 microgram. Threatened abortion 150 microgram. Coming to ICOG and FOXY, what we are following, the good clinical practice aim to prevent sensitization during and after pregnancy. All patients, that is MTP, medical or surgical, should have a knowledge of documentation of blood group and Rh typing. After all sensitizing events in the first trimester, 150 microgram of anti-D injection is required. Mid and late pregnancy sensitizing events and postpartum, it has to be 300 microgram anti-D to Rh negative woman. Due to the lack of availability, important point to be taken here is lack of availability of fetal-maternal hemorrhage volume testing. Administer 300 microgram to protect majority of patients. That is what we all practicing, 300 microgram. This is the other guideline says, that is the British guideline says, it is a little cumbersome again depending on the gestational age, that is 50 microgram less than 12 weeks. They say after that the amount of fetal-maternal hemorrhage has to be measured. Depending on that, the dose of anti-D has to be set. Conventionally, anti-D is produced via fractionation of IgG from the pooled plasma of Rh negative woman immunized with Rh positive RBCs. The resultant IgG is polyclonal in nature and referred to as polyclonal anti-D. Polyclonal anti-D derived from sera of immunized humans made up of mixture of antibodies with affinity for a wide range of antigenic epitopes. The limitations of polyclonal are requirement for human donors, limited capacity of production, theoretical risk of transmission of viral diseases, and of course periodic shortage of donors. Polyclonal anti-D versus monoclonal anti-D versus recombinant anti-D. Coming to monoclonal, highly specific antibodies against single antigenic epitope produced by the clone of a single hybrid cell formed in the fusion. A commercial preparation is available in some countries, including India. Advantages are it is specific, consistent, uniform, safe from transmission of viruses and harmful proteins. Again, limitations are maintaining hybridoma in a stable culture is difficult. Generation of monoclonal antibodies is a time-consuming and laborious process. Since the availability of growth supplements for hybridoma, such as fetal bovine serum, is declining, it further limits the possibility of increasing monoclonal antibody outputs. This is something like comparison between monoclonal and polyclonal. As I already mentioned, the efficacy of monoclonal is greater and consistent, whereas polyclonal is less and inconsistent. Specificity is high here and mixed. Half-life is 23 days for monoclonal, 15.6 days in polyclonal. Purity is highly purified in monoclonal, contains other antibodies and plasma proteins. Batch-to-batch variation, highly homogeneity in monoclonal and variable in polyclonal. Risk of transmission of viral diseases, no risk in monoclonal. Some risk associated with emerging viral diseases. Supply is unlimited supply, monoclonal. Possible periodic shortages due to unavailability of healthy donors. In the first trimester events, as I already mentioned, less than 12 weeks of gestation. These are all the procedures what we routinely do. MTP, surgical and medical ectopic vesicular mole biopsy. In these conditions, dose of 150 micrograms should be given as soon as possible after the sensitizing event. After 12 weeks of gestation, like amniocentesis, abruptio, blunt trauma, IUD, external cephalic version, and placenta previa, it has to be given 300 microgram. A test for a size of fetal-maternal hemorrhage should be done. 10 microgram additional dose of every additional 0.5 ml of fetal RBCs in maternal circulation should be practiced. That is the accurate dose of anti-D. CVS, again, CVS has been estimated to carry a 14% risk of fetal-maternal hemorrhage. Anti-D prophylaxis says there are different, as I said, Canadian people and America, ACOG, all these, they set a different dosages. What we practice, that is immunoprophylaxis with 300, we are following ACOG guidelines like 150 microgram less than 12 weeks of gestation, and more than 12 weeks, it has to be 300 microgram. Cardosynthesis, again, depending on the fetal-maternal hemorrhage and warrant anti-D immunoglobulin prophylaxis. FMH following cardosynthesis occurs particularly if a transplacental route is chosen. Following cardosynthesis, anti-D is immunoglobulin is 300 micrograms should be given to non-sensitized D negative woman. In amniocentesis, if the placenta is implanted on the anterior uterine wall, there is a risk that there will be traumatized at amniocentesis with subsequent fetal transplacental hemorrhage. Amniocentesis led to 2 to 6% rate of fetal-maternal hemorrhage, even if the placenta was not traversed. So, anti-D IgG given after amniocentesis does not harm the conceptus. So, here we take again ACOG 150 less than 20 weeks. Of course, we do 12 weeks. Amniocentesis will be done after like 16 weeks onwards. So, it has to be covered with 300 microgram of immunoglobulins, anti-D. Threatened miscarriage should be given to all non-sensitized RHD negative women with a threatened miscarriage. Again, should be given 6-weekly interval in women where bleeding continues intermittently after 12 weeks of gestation. 50 microgram, right now it is not available in the market. Anti-D should be administered where bleeding is heavy or repeated if abdominal pain occurs at around 12 weeks of gestation. Again, here the prophylaxis, no anti-D for spontaneous complete miscarriage before 12 weeks of gestation, whereas 150 microgram after a complete miscarriage during the first 12 weeks, 300 after 12 weeks of gestation. Prophylaxis following abortion, again it is says between 3% and 11% of women with threatened abortion in the first trimester have FMH. The total fetal-maternal blood volume at 12 weeks of gestation is 3 ml. That is 1.5 milligram of fetal red cells. Anti-D prophylaxis, again here, ACOG says again 12 weeks is the cutoff. That is before it is 150 and after it is 300 microgram. Again, APH, abdominal trauma, ECV, placenta previa, conditions associated with potential placental trauma or disruption of the fetal-maternal interface such as placental abruption, ECV, blunt trauma to the abdomen, placenta previa with bleeding can lead to sensitizing FMH. Has been identified in 296 to 6% of attempted or successful ECV version attempts. Blunt abdominal trauma in pregnancy has also been documented to cause large fetal-maternal hemorrhage. Measurement of fetal-maternal hemorrhage volume is prudent as these conditions may cause FMH in excess of 30 ml. Here again, anti-D prophylaxis, that is 120 microgram or 300 microgram is recommended according to Canadian regime. Here dose of 150 microgram, that is New Zealand and Australia. Mola pregnancy, here also same, the risk of RH alloimmunization in Mola pregnancy is minimal due to absent or incomplete vascularization of villi in complete hydatiform mole, absence of D antigen on the villus trophoblastic. The diagnosis of partial versus complete Mola pregnancy depends on pathologic or cytogenetic evaluations. Reasonable to administer anti-D RH negative woman suspected of Mola pregnancy and WHO who undergoes uterine evacuation. That is, according to ACOG, anti-D immune globulin 2 RH negative women who are suspected of Mola pregnancy or undergo uterine evacuation, again definitely 150 microgram of. Coming to postpartum prophylaxis. Postpartum prophylaxis, all RH negative patients who deliver a RH positive baby either by a normal delivery or by cesarean section receive 300 microgram of anti-D within 72 hours of delivery, where we are all practicing the same. There is risk of isoimmunization of 1.5%, that is in the first pregnancy, and in the second pregnancy, of course, the woman is after the immunization, the second pregnancy is escaped. First pregnancy is escaped, and second pregnancy we need to immunize the mother. Just. Thank you. Thanks for the opportunity given, ma'am. I think I have done my justice.
Thank you, ma'am. Thanks a lot, Dr. Rekha.
Yeah, requesting the chairpersons to give their comment or some opinion on this topic.
Dr. MC Patel, sir, has joined. Welcome,
Okay.
sir.
Yeah,
So we
welcome,
will
Dr.
just finish this session, sir, and then
Yes,
I
good.
will call you for your welcome address.
Oh, yes.
Namaskar, most welcome.
Yes.
So it went on seamlessly, and there was no problem. We proceeded, and the first talk is over.
So
Chairperson,
can I-
anything you want to tell? Yeah, Suman madam.
Yes, sir. Thanks, Dr. Shobha Dhananjay, for the very comprehensive presentation on our RH negative pregnancy. You have spoken about the various guidelines, but I would like to highlight on our Government of Karnataka under
Yes, ma'am.
NHM released guidelines for the management of RH negative pregnancy, which was just recently released on 25th of Jan 2024. So elements critical in the management of RH negative mother, first thing is screening of the RH status of the pregnant woman and the spouse. Then documentation of this RH status of the antenatal care in MCP card, also in RCH portal and PMSMA portal and maternity case sheets. Documentation is very important. Then screening of every newborn for RH status, of course. That we have to decide for the whether to give the anti-D postpartum. Then adequate stocking of the anti-D immunoglobulin at the facility based on caseload. That is very, very important. If you don't have adequate stocking, then it is difficult. Then for the administration of injection anti-D, of course, as all the guidelines says, 300 micrograms after delivery of the baby and 150 micrograms after abortion or ectopic or molar pregnancy. Now, the only thing is currently there was no actually in the talk regarding the antenatal administration of anti-D was not really mentioned actually. But currently this guideline says, Government of Karnataka says, currently administration of anti-D injection immunoglobulin not recommended by the Government of Karnataka. Currently, it is not recommended. So these are the latest guidelines, which is released last month. So I just wanted to just bring it to this webinar.
Thank you very much, ma'am.
Madam, what is that? Please repeat. What is not recommended? I didn't get it.
Administration of injection anti-D immunoglobulin during the antenatal period, which some textbook theory, they say that at 28
be
weeks you
given.
should give
Should be
one
given.
dose, or sometimes people give even 2 doses at 28 and 34 weeks. This is not recommended by the government of Karnataka under NHS.
Okay, fine. Thank you.
Antenatal prophylaxis.
Understood. Understood.
Prophylaxis for primaries, and we do the ICT and we give them 1 dose of anti-D at
Yes,
20.
yes. 30
Yes,
to
we do
28.
give at around 28 weeks of gestation. We do give. If the ICT is negative, we are supposed to give according to ACOG guidelines.
Yeah, that is according to ACOG.
ACOG.
But this, I just wanted to bring out this point. That's all. Thank you.
Thank you, ma'am.
Dr. Lalitamma. Lalitamma, madam.
Yes, sir.
Dr. Lalitamma, madam.
I think she's not there.
Yeah, I think, we can't find her. Thank you, Dr. Shobha. Well presented. We close your session here.
Thank you.
It's my utmost pleasure to welcome MC Patel, sir. Sir, we would like to listen to you.
So thank you, Rekha. Welcome all the participants of today's webinar. It is 179th episode of our Happy Learning Masterclass web series. Bellary, Bidar, Chitradurga, Davangere, Gadag, and Raichur. I welcome Dr. Shukla Sethi Madam. We had kindly consented to be chief guest, and Dr. Jammunath Gowda and Virendra Kumar, guest of honor, who had kindly consented to be guest of honor, and all they have blessed us, I hope, because I have joined just now. I also welcome Dr. Vidya Dubey, Kasoga president, for her blessings also. I also welcome Shobha Dhananjay madam, who has just completed very interesting talk about Rh negative pregnancy, and all the learned chairperson, Selja Bidari madam, Dr. Suman Gadi madam, who has completed with their her comments and guideline from Karnataka state, and Lalitamma madam from Bidar. I also welcome all the learned panelists who are going to ask question or put query during panel discussion in reverse panel. Siva Kumar from Bellary, Pranathi madam from Bellary, Uma Deshmukh madam from Bidar, Rameshwari madam from Bidar, Jyoti madam from Chitradurga, Rasmi madam, due to ill health she couldn't join, but I acknowledge. Dr. Rasmi Shetty madam from Davangere.
Dr. Rashmi madam has joined.
Rasmi Shetty is not joined.
Yeah.
Okay, yes. Vijay Kumar from Davangere, Shruti Bhavi Patil madam from Gadag, Dr. Annapurna madam from Gadag, Dr. Mangala Gadwal madam from Raichur, Dr. Sushma madam from Raichur, Dr. Harsha from Davangere, and Dr. Abhinetri Patil madam from Raichur. I also welcome Dr. Asha Jain, convener of this series, and she is working as a convener since long in this series, and two coordinator, Dr. Bharti Raj Shekhar and Dr. Rekha Rajendra Kumar. Rekha Rajendra Kumar is also in this series since long, and Dr. Bharti madam, whenever we have invited Dr. Bharti madam, she is always there to help us, to guide us, and to assist us in any of our academic activity. So I acknowledge all this, Dr. Bharti madam. So let me say sorry first to be late to join, but I would like to share that incidence also why I was late, and it is eye-opening in our day-to-day practice. Just day before yesterday, it happened with one of our gynecologist friend at Ahmedabad. Patient was brought, it was book patient was brought in emergency with IUFD, and it was declared that it is IUFD. Patient was admitted, she was delivered, but she was already processing towards DIC. Patient went into DIC, blood transfusion were given, products were given, and ultimately when bleeding was not getting control, so hysterectomy was advised. Relative opted option to ship patient to another hospital, and they left the hospital, but before they reached to next hospital, patient expired on the way. And yesterday only, there was a mob of so many people came to the hospital, ransacked hospital. It was damage to the hospital, and taking a kerosene, etc. They were to fire hospital. Police was informed, police came, everything was getting under control. So on part of association, that is Ahmedabad Gynec Society, IMA Ahmedabad, State Gynec Society of Gujarat, because I am Secretary of State Gynec Society also. We had been to DCP because FIR is already launched day before yesterday only when this incidents happened. But today we met him, and 3 culprits are already arrested, and now let us see how case goes on in court of law. But I had been to DCP to represent all this case on behalf of our gynec friend. So in our day-to-day practice, many a times whenever I start any of my talk or any of my panel, I put a question: is it worth discussing medical legal issues in our day-to-day practice? So this is incidence. Whenever we never know when this type of incident may happen, because in our obstetric practice, we take utmost care of any of our patients, but accident may happen. And whenever something goes wrong, then it becomes a very potential condition as far as medical legal problems are concerned. And this type of attack to the hospital, but even staff was also injured yesterday. So in this situation, it becomes very difficult, but police came well in time, and before something goes much wrong, it was under control. But this may happen, so that is why we should be very vigilant in our day-to-day practice. And whenever we are dealing with this type of cases, IUFD, or patient is going towards DIC, or we know that prognosis is guarded or not good, then proper counseling with patient and relative. If patient is not in a position, then of course with relative is very much important. And we should discuss very quickly our treatment plan and probable prognosis. They are free to take patient to another hospital, no issue. But if we have counseled well, then in this type of situation, it becomes good defense in our favor. So with this type of incidents, when I started this series long back in era of Corona, we 3 people started this series, and now we are, I am happy to announce, we are now 7,000 plus members as far as this Happy Learning Masterclass series is concerned. And when we started this series, we decided to discuss one topic related to medical legal issues in our day-to-day practice. And this is our 4th round. We have completed 3 rounds of all the Society of Foxy. And in 4th round, we have started a reverse panel. So in this, panelist will be asking question, and being a moderator, I will be answering. So sorry again to be late to join this series, but I was for a noble cause to help our Foxian friend in that very given situation. So over to you, Asa and Rekha, for further
Thank you,
questions.
sir. Thank you. Thank you, dear coordinators, Dr. Rekha, Dr. Bharti. Thank you, respected Chief Guest Shukla ma'am, our guests of honor, Dr. Jambu Gowda sir, and Dr. Virendra Kumar sir. Thank you, chairpersons and speakers. So may we start the panel now, sir?
Oh yes, but before we start, I would like to express my deep sense of gratitude to Dr. Shukla Shetty madam, Jambu Gowda sir, and Virendra sir. They have kindly consented to be chief guest and guest of honor respectively, and they have joined and blessed the webinar. I couldn't welcome them before their blessings, but I thank you all of them. Thank you, ma'am. Thank you.
Thank you, Dr. Patel, sir, for having given us a chance. Thank you for making me the chief guest. Thank you. And I always enjoy seeing your interaction, and it is a pleasure to watch every Tuesday. So many topics discussed, because we as a profession, as teachers, we don't know the other part of the world. So it is a real, not only for practitioners, for everyone, it's such a wonderful insight, what you give, what you discuss in detail. Thank you very much, sir, for inviting me to
Yes.
be in this
Yes.
panel. Thank you. Thanks a lot.
Yes.
Sir, I would like to ask one question with your permission regarding that
yes.
unfortunate case. Can you tell us what was the cause of IUD? And
She was brought when she was brought. It was already IUFD.
that's what they could not find out the cause of IUFD.
No. So she was admitted. She was delivered.
Okay.
But after delivery, she went into PPH and DIC was. She was going towards DIC. Blood
Okay.
transfusion and these products were given, and they ultimately decided to go for hysterectomy, but they were not ready to go for hysterectomy, and they decided to ship patient to another hospital. And
Understood.
during shipping patient to another hospital, patient expired on the way. On that day, they didn't turn up, but next day, matlab yesterday only, this happened day before yesterday. So yesterday only, there was a big mob came to the hospital with kerosene, kerba, etc. And they were mentally prepared to burn the hospital totally. They were ready to fire the hospital. So they sprayed the kerosene in the hospital, but staff were very vigilant. So immediately they phone call to their doctors as well as police station, and police came and everything was under control. But before police came, they damaged hospital in a big way. All the glasses, etc., were broken very badly.
So scary.
So
Okay.
FIR is launched, and we insisted, and police officer was also very kind to accept our request, and section 307 is applied because they tried to attempt to get injured our staff, etc. So section 304 and section 3023 of IPC are applied with other sections also. 307 means attempt to murder, and 323 is injury, simple hurt, and 324 grievous hurt. So all these sections are applied against culprit. 3 culprits are already arrested, and rest of the culprits will be arrested after their rituals are over in their family.
Yeah.
But police was very serious about
May
this.
we start the program, sir?
Oh yes, oh yes, oh yes.
And it is my request to all the respected panelists, let us finish the scheduled questions first before we ask additional questions, please. And as madam is not here, she is not well, Dr. Rashmi Shetty, I would request Dr. Vijay, who's also from Davangere, to please take those questions. So may we start the program now?
Oh yes.
So I would like to, we are going to have a panel on consent in the Indian context. I would like to introduce MC Patel, sir, though he is a very well-known figure and this is his own brainchild, but still it's an honor and it's good to be reminded of all his achievements. So he's a consultant obstetrician gynecologist and medical legal counselor. He was VP Foxy 2018, Organizing Secretary ICOG 2017. He was the chairperson Ethics and Medical Legal Committee 2011 to 13, and he has never stopped being a medical legal person and has been helping everyone, as you can see in this. So he has many other posts and positions, but to me, what is most notable is that he's always there on a single call for everyone. And also in the Northeast, he's been going and having camps for the people who cannot afford care for the last 21 years. So that is, I think, the biggest plus mark that we have in Sir is consistency. We have, this is the 179th episode, consistently week after week, and going for camps for 21 years. 1 or 2 years is fine. So namaskaram, sir, for your consistency. I welcome you. And I would, on behalf of, that's me, and you've already known about me. So I would like to welcome everyone with this short video from sir.
शुभं करोतु कल्याणम् आरोग्यं सुखसम्पदम्
respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
ये साफ होने के बाद So with that, we start the panel. These are our respected panelists, and I will be taking their introductions as their questions come along. Welcome, everyone, and I request all of you to please put on your videos so that we can make sure that you are there. Sir, before we actually start the program, as you said that this is the first thing we ask, we are talking of consent. Is this topic not self-explanatory? Is it worth discussing?
Yes, of course it is worth discussing, because many a times when consent is not taken or patient party is not explained about treatment plan, and if something goes wrong, then it becomes very difficult in court of law to face the situation. So it is always necessary to discuss this type of topic. And what is ideal consent in Indian context is the theme for today's discussion.
Sir, and has there been any important case that has been decided on the basis of only consent?
Yes. So a very famous case of Samira Kohli versus Prabha Manchanda, which was decided in 2008 in Supreme Court. And it was case related to our fraternity only, gynec fraternity, and it was for diagnostic laparoscopy. And in that very case, Supreme Court came up with guidelines, what should be the ideal consent in Indian context, and when consent becomes valid in eye of law was discussed during that very case, and Supreme Court gave all this guideline for any consent to be valid.
Thank you, sir.
Yes.
Now, the first question will be going to Dr. Shiv Kumar HC. He is the president of Bellary Obstetric Gynec Society, and he is an avid chess player. So, over to you, sir. Dr. Shiv Kumar, sir.
MC Patel, sir.
Yes, welcome.
There is always confusion between the two words, agreement and contract. So is the agreement and contract are same or it is different?
No, it is little difference. When two or more persons agree upon the same sense, it is an agreement. Say for example, if we decide that let us go to movie this evening, and we both are agree, then this is agreement.
Okay.
But when any agreement is enforceable by law, then it becomes a contract. Say for example, we have decided to go for a movie, and for any reason I cannot come. It doesn't become much problem as far as law part is concerned. But if it is enforceable by law, any agreement enforceable by law, it becomes a contract.
Okay, sir. Contract means it's enforceable by law.
Agreement with agreement enforceable with law is contract.
Okay, sir. Then what is consent under enforceable law or Indian contract?
So under Indian Contract Act, usually whenever any patient enters in our clinic and we accept her to treat, then it becomes a contract between patient and ourselves. It is contract or implied contract, we may say. But if we go by Indian Contract Act, Section 13, in that very Section 13, it is very specifically mentioned that two or more persons are said to consent when they agree upon same thing in a same sense. So whatever we explain to the patient should agree in the same sense, same thing. So it becomes a contract.
Right. Okay, sir. Then what is consent in medical field, sir?
So in medical field, when any patient or in few of the cases on behalf of a patient party or relative gives us voluntary agreement with compliance or permission without any compulsion to manage that very case in that very given situation is a consent in medical practice.
Okay. Thank you for the information.
Yes.
Thank you, sir. Now we have Dr. Pranita Ajay. So she is the secretary of Bellary Society and she is very fitness oriented, does a lot of running, dancing, singing, aerobics. So over to you, Dr. Pranita.
Good evening, sir.
Good evening. Welcome.
Sir, now, could you please tell us what is a valid consent, sir?
So, any consent which is lawful and person who has given the consent is capable of giving that very consent, and if it is voluntary and if it is informed one, then it becomes a valid consent. So consent should be for lawful act. Say for example, if any patient says that I am tired of this disease or my life and please give me injection so that I can die. So it is not lawful consent. So it is unlawful. So consent should be for lawful act. It is very clear. Capacity, who can give consent? Person who is capable of giving consent and has given consent, then it is a valid consent. It should be voluntary without any force and it should be informed one. So if any consent fulfills all those criteria, then consent becomes valid.
Could you please tell us what are the criteria for the consent, sir, valid consent?
So,
the same.
Yes, same. As far as capacity is concerned, say for example, then many times we have a question, then who can give consent? So any adult patient who is mentally sound can give consent. If patient is minor or if patient is mentally challenged, then guardian will give consent. So this is a capacity of person who can give consent.
Okay,
Capacity,
sir.
we can call it competence also. Who can
Yes.
give? Yes.
So the minor and mentally retarded, in that
Yes,
case, only
yes,
guardian
yes.
can.
Guardian can give consent.
For
Yes.
any examination or surgery or any such procedure, only the guardian should.
Any treatment plan, whenever we are going to treat any patient with any invasive thing, investigation or indoor treatment or surgery or any procedure, then we have to counsel patient and we have to take consent.
Thank you, sir. Thank you. Thank you, sir.
Yes, welcome.
So next we have Dr. Uma Deshmukh ma'am. So she's the president of Bidar Society and she's very spiritually inclined, does Rudra Path, and for relaxation she would maybe see some serials. So over to you, Uma ma'am. Dr. Uma?
Is she there? Uma
Yes,
madam?
I saw her there. Can't see her anymore.
Yes. So any other delegate from Bidar can take, no issue. Or anybody can take.
Shall I take, sir? Shivkumar.
Oh yes. Oh yes.
Sir, can mentally challenged give consent?
No, mentally challenged, just I mentioned also. In this situation, guardian will give consent.
Sir,
Okay.
hello, sir.
Yes, welcome.
Sorry, good evening, sir. I'm
Good
Dr.
evening.
Uma Deshmukh.
Yes.
And in a mentally challenged patient, whether we need a psychiatrist certificate?
So if we consider her to be mentally retarded, and if it is supported by a certificate from psychiatrist, it will be always better.
Whether sometimes on seeing it may not be like she is a mentally retarded. That time we need a psychiatric certificate.
Yes, yes.
Yes, sir. Then can deaf and dumb can give the consent?
Yes, deaf and dumb can give consent, but if he can read whatever you have written in your consent paper, so all the points of counseling, and if he can read, because he is deaf and dumb, but he is visually not challenged, so he can read, and if he agreed with all the after reading, and if he is able to sign the document, then she can give consent. But in this case, one witness should be on part of patient, that everything written in that very consent paper was given to this patient. She went through all this, and after this she has signed before me. So if we take signature of witness that it was signed before him or her, then it becomes a valid consent, even if patient is deaf or dumb.
Sir, what about here the certification is necessary for deaf and dumb?
So again, it is a abundant caution. If you have certificate of this kind, it's fine. But
and what about
why patient will mimic as if she is deaf or dumb? Usually, no patient will do like this.
No, for about the blind patients.
Blind patient, this is one more area. If blind patient is able to listen us, so if he is able to hear, then we will explain everything as far as this treatment plan is concerned, surgery is concerned. And if he or she agrees, then he or she can sign. But again, in this situation also, there should be one witness on their behalf, and he will sign the document that before me, everything was explained, whichever written in this paper, and after that they have signed the document. And in few of the hospital, big hospital, it is available in Braille also, because visually challenged people may go through Braille language, and they can give consent.
Along with this mentally, this one deaf, dumb and blind, we have to take the another person's signature.
Yes, naturally, because it is abundant caution. They may sign like this before us. Everything was explained to the patient, and then after patient has signed the document.
And all these, whatever consent we are taking in a writing, whether we have to record it and.
Excuse me, ma'am, that will be coming later in next questions.
Okay.
Just hold on. Thank you, ma'am. Now we have Dr. Rameshwari Malashetty, ma'am, who's the secretary of Bidar Society. Her hobbies are cooking and painting, though she didn't send me any painting. So, Dr. Rameshwari, over to you, ma'am, please.
Good evening, everyone. Good evening, sir.
Yes, welcome.
So, who will give consent in the emergency conditions?
In emergency, no consent is required. But burden of proof will be on your shoulder to prove that it was dial emergency, and to save life of patient, whatever you did, you should be in a position to justify. So if it is an emergency, consent is not required.
Okay, sir. What is informed consent, sir?
So as far as informed consent is concerned, we will have to explain everything to the patient, what is our treatment plan and what we are going to do. Say, for example, we are going for cesarean section. Then what is informed consent related to cesarean section? We have to explain what is cesarean section, what we are going to do, why cesarean section is indicated. And if patient is not ready to give consent, then which are the consequences of refusal? Which are the benefit of cesarean section? Which are the probable complication related to cesarean section? So everything related to that very surgery or our treatment plan should be explained to the patient. So it is called informed consent.
Yes. Thank you, sir.
Yes, welcome.
Thank you, sir. Now we have Dr. Jyoti Sharat Kumar ma'am, who's the president of Chitradurga Society. She loves gardening, cooking, music, and in all my search, she's the first one to do interior design. So over to you, Dr. Jyoti.
Madam, thank you, madam. My question is, good evening, sir. Good evening to all delegates here. The Supreme Court expects us to talk about all possible complications, sir.
So, in that very famous case, which I mentioned in beginning, Samira Kohli versus Prabha Manchanda, Supreme Court has very specifically mentioned that one should anticipate certain complications and one should be readily available to deal with those complications. And court has very specifically mentioned also, no need to explain about remote complication or theoretical complication many times we may say, so that patient may be frightened and patient is not ready to give consent. Because if we explain all these very, very remote complications or remote consequences, it is not expected from court also. So we have to explain common complications or probable prognosis with that very situation.
What about the remote complications?
Remote complication, just I mentioned that court also has said very specifically, no need to explain about very remote complications so that patient may be frightened and patient doesn't become ready to give consent for necessary treatment. So balance should be achieved at the time of explaining all these complications.
Thank you, sir.
Yes.
So, Dr. Rameshwari ma'am is also an LLB. So
very good. Welcome, madam. Welcome to Club of LLB.
Yes, sir.
So she will be able to ask you more questions at
the
end.
Oh, yes. Most welcome.
So, sir, now we have Dr. Rashmi S., who's the secretary of Chitradurga Society, and she loves music and that also classical music. So over to you, Dr. Rashmi.
Thank you, ma'am. Thank you for the chance. Good evening, sir.
Yes, welcome.
My question is, if either the patient or the patient relatives, if they refuse to give consent, so then what to do in that situation, sir?
So this is very common situation in few of the condition. Patients are not ready to give consent, or they will explain that our husband is not present, he is at home, he is coming, when he will come, then we will give consent. So these are very usual situation and they refuse to give consent. So at that time, in that very case, Supreme Court has come up with guideline, need to explain risk of refusal of treatment. If consent is refused, then which are the risks involved in that refusal? If consent is not given, if treatment is not given well in time, then which are the common consequences in that very given situation? We have to explain that. And even after explaining, many times patient or patient party may be ready to give consent, but in few of the conditions, they will be very reluctant to give consent.
Yes, sir. So you mean to say we have to explain them what can happen if they don't give?
Yes. Risk of refusal of consent. Yes. So what is risk of refusal? If they do not give consent, and if we do not proceed with the treatment further, which is needed at that very point of time. So all the consequences possible, not taking treatment well in time, we have to explain.
Is there any role of negative consent, sir?
Yes, naturally. If patient is not ready to give consent, then we should ask to give negative consent. Negative consent, we had been explained that this surgery or this treatment is needed, but we are not ready to give consent. So if they give consent like this, it becomes good defense in your favor. Because whenever any patient doesn't follow your instruction, doesn't give consent, then it becomes contributory negligence on part of patient, and it is a good defense in your favor.
If they refuse to even to give a negative consent, sir.
Yes, then it is also very common situation in many of the hospitals. They are not ready to give negative consent also. So in this situation, you can have a signature of any co-patient or any visitor of hospital that it was explained before us about the need of that very surgery or that very treatment, and patient party were not ready to give consent. So if you have taken this type of negative consent, I mean consent by a co-patient or any visitor of hospital, it will be in your favor. But in this situation, you will have to explain to the co-patient or in that very visitor what is the situation and why they have to sign this document. And you will have all the details of that very person with address, mobile number, etc. Because in future, if at all he or she may be required to be present in court of law. Of course, it is rare condition. Court doesn't usually invite all this type of persons, because once we show document, court usually agrees. But many times, advocate on part of prosecution may insist to call that very person. So if we have taken signature like this, then that very person should be traceable whenever it is needed.
Can any other healthcare person can consent?
As such, any person can give consent, but preferably he or she should not be your staff or member of hospital management, because many times they will say that it was your staff, she was your staff, so this consent is not valid. So it is always better to give consent of third party, that is independent person. Any co-patient fine, any visitor of hospital fine.
Thank you, sir.
Thank you, sir.
Yes.
Thank you. So next we had the question for Dr. Rashmi Shetty, the president of Davangere. She is not joining. So I would request Dr. Vijay Kumar, sir, who's the secretary Davangere, and his hobbies are to travel around the world and do a lot of reading. So over to you, Dr. Vijay Kumar, sir.
Good evening, sir.
Good evening.
Can we take the consent by the assistant doctors or the staff?
Yes, anybody can take consent, because if we have prepared consent and all the important points we have mentioned in that very consent paper, person who is taking consent will explain all these points. And if patient is agreed after understanding all those points, patient can sign in presence of assistant doctor, and assistant doctor will also sign that very consent paper. And with two witnesses, one witness in favor of patient and one in favor of hospital.
Okay, sir.
So assistant doctor can take consent, can counsel patient.
Okay, sir. Can there be common consent like for diagnostic and operative procedure together?
Yes. So if it is plan one prior, say for example, if it is a case of infertility and it is a PCOD, and we have planned diagnostic laparoscopy with ovarian drilling, then we can go with common consent for diagnostic laparoscopy and consent for ovarian drilling or any operative procedure, I would say, if it is addition, so adenolysis. So that way, but prior consent is very much required. Because if consent is given for diagnostic laparoscopy only, and after putting scope, if you find that it is a case of PCOD, and if we go with ovarian drilling, then patient will be benefited in future. But if consent is not given for ovarian drilling, you cannot go with ovarian drilling. Because in one of the cases, compensation of 25,000 was awarded in favor of patient. So consent should be very specific, procedure specific. Whatever you are going to do, it should be mentioned in consent paper.
Can there be common consent for particular surgical procedure and additional procedures?
Yes, yes. Say for example, if we have taken consent for hysterectomy, abdominal, vaginal or endoscopy, and nowadays it is almost a routine that if hysterectomy is done, bilateral salpingectomy is also done. So if prior consent for bilateral salpingectomy is taken, then we can very well proceed with hysterectomy with salpingectomy or oophorectomy or salpingo-oophorectomy, whichever the case. But prior consent should be taken for particular surgery and additional surgery.
Okay, sir.
Yes.
Thank you,
Next,
sir.
my questions.
Yes, sir. See his travels.
Can we allow attenders during surgery?
Pardon?
Thank you.
Yes, yes.
Can we allow the attenders during surgical or diagnostic procedures?
So if patient is comfortable and if patient has given consent, then we can allow.
Okay.
But prior consent
Can
is
we
very
record the surgery? Okay.
Yes, same way. If, as far as recording is concerned, if patient has already given consent for recording, we can record. But in this situation, word of caution, it is for academic purpose only. So we will mention that whatever we are going to record, it is for academic purpose. And if patient demands that very recording, then we can give, or we should give rather, that recording to patient also.
Okay. Can we display the recording in teaching class, CME workshop and conferences then?
So again, prior consent should be taken at the time of taking consent, that she is willing to go for recording and she has given consent. Therefore, academic purpose, if this recording is displayed in any CME, any workshop, any conference or in teaching class, then I have no objection. Then we can. But in this situation, word of caution, we should be very careful. Personal identity of patients should not be revealed. When we are displaying this surgery in any conference, workshop or so, then personal identity of patient should not be revealed.
Okay. Thank you, sir. Thank you.
But one thing is very clear. This should be for academic activity or academic purpose only, because many a time what happens, a few of our friends have a habit. They have done some very good surgery and they will put it on WhatsApp or on Facebook or on YouTube, etc. So in this type of situation, many a time patient or patient relative may show that it is unfair trade practice, because whatever you do to enhance your business, it becomes an unfair trade practice, and this type of display is not allowed. Even NMC has also given guideline. If it is for academic purpose, it's fine. But if it is for advertisement purpose, to enhance your business, enhance your practice, then it is not allowed.
So thank you, sir. Thank you very much.
Sir, I think that is a very thin line that we have, you know.
Yes,
What
yes.
is academic and what is advertisement? But
Asha, in this situation, patient can display. If patient is interested to display this on YouTube or in any other social media, patient can. But
no, sir, but so many doctors are displaying a number of things, you know.
this is not good practice, because if NMC came to know, and if NMC is serious one, then they will be issued a notice also, because few of our friends have been issued notice for this only. Why you have put all this surgery on social media? You are enhancing your business. That this type of notice is served from NMC to few of our friends also.
So thank you, sir.
Yes.
Thank you, Dr. Vijay. Thank you. So now we have Dr. Shruti Bhave Patil, ma'am. She loves dancing, anchoring, and she also writes poems, but she didn't have any poem ready with her. So over to you, Shruti, ma'am.
Good evening, everyone. Good evening,
Good
sir.
evening. Good evening. Welcome.
Yeah, ma'am. Yeah, ma'am. I would have given actually if I was in station. So sorry for that. Sir, my question to you is, like, during any surgery, would you take a separate consent for anesthesia?
Naturally, yes.
Yes, sir. But
But
like usually the
for
anesthetist.
surgery and for anesthesia, it should be separate consent.
Yes, sir. But the anesthesia people will be taking
So
their
he
consent
is
separately.
the best person, because all the things related to anesthesia, probable complications, or how anesthesia will be given, which kind of anesthesia will be given. So he is the right person to explain. So we should always insist anesthetists also to take consent as far as anesthesia is concerned.
Okay. Like no, I wanted to ask whether the surgeon has to explain about the anesthesia and take consent as well?
Anybody can explain.
Anybody
Surgeon can
can.
also explain about risk of anesthesia. But if anesthesiologist explains, then he will be the right person to explain. Otherwise, surgeon cannot explain. This is not like that. Surgeon, any of your staff also can explain. He is well versed with all these details.
Okay, sir. So what all should be explained in that? So all
Yes.
the risks and advantages.
So it is very clear. Everything should be explained to the patient by responsible person, surgeon, anesthesiologist, or your staff or your assistant, whosoever.
Okay, sir. Similarly, like for blood transfusion also, sir, would you take
Yes. So for blood transfusion, separate consent is very much required, because in one of the case, court had a comment that surgery involves risk and blood transfusion involves additional risk. So separate consent should be taken. In that very
Right.
case, court has very specifically mentioned.
Okay. Even if it is done during the surgery also, there should be a separate
If
consent.
it is an emergency, it is a different story. But
Okay.
if you have planned well in advance, then separate consent should be taken. But word of caution, at the time of taking surgery, one line should be mentioned that if at all blood or blood product transfusion is required, I give my free and fair consent for that also. So you are safe.
Thank you very much.
Yes.
Thank you, sir. Now, the next person coming up is Dr. Annapurna Dhanur. She loves sketching, drawing, and painting, but I don't have a sample. So over to you, Dr. Annapurna, who's the secretary of Gadak Society.
Yes.
Thank you,
Annapurna
ma'am.
madam. Yes, welcome.
Thank you, ma'am. Good evening, sir.
Good evening.
Sir, my question is written consent is mandatory?
So if we go by law, there are only 3 conditions where written consent is very much mandatory by law. Say for example, organ transplantation. In organ transplantation, written consent is very much mandatory. In case of termination of pregnancy, written consent of patient is very much mandatory. And in case of antenatal sonography under PCPNDT Act, written consent is very much mandatory. Other than all these 3 conditions, we can go with oral consent also, but burden of proof is on your shoulder to prove that you had explained and patient has given you a oral consent. And many times patient may go hostile in court of law. So though it is not mandatory, but I would advise it is always preferred, always advisable to go with written consent.
Okay, sir. Thank you, sir. Next is, can it be taken on a pre-printed form or just a written?
Yes, it can be taken on pre-printed form also. But if patient writes in her own handwriting, it's fine. Or surgeon writes in own handwriting, it's also fine. But we can take consent on pre-printed form also. I would like to mention that famous case of RG Stone Hospital versus Vinod Khanna. In that very consent, after everything went fine, patient was discharged, and if I that I have no complaint as far as my treatment part is concerned, but my consent was taken in pre-printed form, and it becomes an unfair trade practice. Case was filed, and case was decided in favor of that patient, and compensation of 10 lakhs was awarded to that very patient. So when we were preparing uniform consent at Foxy level, this case was happened. So we approach that hospital to prefer appeal, because if this judgment is not challenged, then we cannot use pre-printed form, consent form. So ultimately, hospital was convinced and appeal is preferred. And at the time of allowing this appeal, I mean admitting this appeal, argument on part of us, that is medical fraternity, was what is unfair trade practice? Unfair trade practice means any means in unfair way to enhance business is unfair trade practice. So if we take consent in pre-printed form, does it increase our practice? It is not like that. If we take consent by patient's own handwriting or by surgeon's own handwriting and in pre-printed form. Does it make any difference as far as enhancement of our practice is concerned?
No.
And it was convinced. So appeal is admitted and we are waiting for final judgment because this appeal is pending. But we are quite hopeful. Result will be in our favor.
Okay, sir. So next, it should be in English or in their own vernacular language, sir?
If it is in vernacular language, it is always preferred. But if it is in English, then at the end of consent, we should write like this. Whatever written above was explained to me in a language which I can understand. And all the questions related to that were answered to my satisfaction. And then after I have signed the document. Once patient has written like this, or even if we have written and patient signs, that very part should be written in vernacular language. So if patient has signed the document, then it is accepted by court. Whatever written above, where patient has put signature, is acceptable to me.
Okay. So next, who should sign the consent, sir?
So patient, naturally, when patient is major and mentally sound, otherwise guardian, if patient is minor, mentally challenged, or in any other special condition, and two witnesses, one in favor of patient, one in favor of hospital, and person who has taken consent, like doctor or assistant doctor or staff, should also sign the consent.
Okay, sir. Okay, thank you, sir. Thank you.
Yes.
Thank you, sir.
Yes.
Thank you, Dr. Annapurna.
Thank you, ma'am.
Now we have Dr. Mangala Garwal, ma'am. She likes reading, music, and gardening, and she's the president of Raichur Obstetric Gynec Society. Over to you, Mangala, ma'am.
Good evening, madam. Good evening, sir.
Yes,
Thank you for.
welcome.
Can one do salpingectomy with hysterectomy, sir?
So if prior consent is taken, then yes.
Okay. Can one do myomectomy with cesarean section?
Same. With cesarean section, one can go with myomectomy, but prior consent for myomectomy is very much required. But there is one point also. If myoma is on the way to deliver baby and prior consent is not given by patient for myomectomy, then also you can very well proceed with myomectomy and to deliver baby. But if myoma is not on the way to deliver baby and prior consent is not given by patient, then you cannot go for myomectomy.
Okay. Okay, sir. Can one do tubal ligation with cesarean section?
Again, yes, if patient has given consent for tubal ligation with cesarean section, then of course you can go. But in this situation, word of caution, because tubal ligation is a national program, and for any reason, for due to complication of cesarean section, if something goes wrong, complication of surgery or so, patient may sue, and in this special investigation, because being this national program, tubectomy or tubal ligation, special inquiry will be there. So many of our friends have in their mind, better not to go with tubal ligation and cesarean section together. So they prefer to go for tubal ligation separately. But legally, you can very well go with tubal ligation with prior consent of patient with cesarean section.
Now, for while doing hysterectomy, sir, for
Yes.
salpingectomy and oophorectomy, we have to take separate consent again?
Naturally.
Yeah.
Naturally.
Okay. 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 Thank you, sir.
Yes.
Thank you, sir. So now we have Dr. Harsh B from Davangere. He's a senior consultant gynecologist over there, and he does adventure travel. So over to you, Dr. Harsh. You're muted. You're muted.
Yes, Harsha sir.
Good evening, Dr. MC Patel sir, and all the panelists.
Welcome.
Thank you, sir. Is consent of the spouse required for sterilization, sir?
Sterilization, there are two views. In one of the cases, court has said when you are going to put full stop on reproductive capacity of that very couple, then a spouse should be taken into consideration and signature of spouse is required. But in so many states, there are circular on part of that respective state government that consent of husband or a spouse is not required. So if this type of circular is there, and if you follow that circular, then also you are pardoned in court of law, even if you have not taken signature of a spouse.
Which states do what all states, like, if you know?
So say for an I quote of my state, Gujarat. In Gujarat, there is circular on part of government that during sterilization operation, consent of husband is not mandated, not required. If you can explain him or her on telephone or and if he is willing, it's fine. But if you have not taken signature on that very form, it is not that you cannot operate for tubal sterilization operation. In Gujarat, it is government circulars. In so many states, not in Gujarat only, but in so many states, there are circular on part of respective government that consent of husband is not mandated.
Do we need consent for obstetric sonography?
Naturally, yes. Under PCP NDT Act.
Thank you, sir.
Obstetric sonography will come in purview of PCP NDT Act. And under PCP NDT Act, consent of a person undergoing sonography is very much required.
Excuse me, sir. So
Yes.
for PCP NDT, the consent is only that you will not ask the sex of the baby.
No, this is
That is
declaration.
the only consent that we take
No.
from the patient.
No. Let me clear. This is declaration on part of patient. What she is writing. I do not want to know sex of my baby. This kind of writing is there as far as declaration is concerned. But nowhere in that very declaration she has written that I am willing to go for this procedure or test or technique or sonography or whichever. So in section 4 subsection 3 and section 5 subsection 1, it is mentioned that consent of patient is very much required. And particularly when you are going to go for invasive procedure, then it is very much required to go for written consent of a patient, explaining all the side effects and after effects of that very procedure, invasive procedure. Say, for example, if you are going to go for amniocentesis, then in this situation, we have to explain about side and after effects of amniocentesis, and we have to take consent of patient. That also, mere declaration in this situation is not sufficient.
So that means a separate consent has to be taken.
Yes. Of course, it will be of 2 to 3 lines. I give my free and fair consent for sonography or oblique invasive procedure. But for invasive procedure, again, you will have to mention that I had been explained about its after or side effects as far as this procedure is concerned. And it is in prescribed form, that is Form G. In Form G, everything is mentioned about this after effects, side effects, etc.
Thank you, sir.
Thank you, sir.
Yes.
So, sir, we have our last panelist, that is Dr. Abhinetri Patil. She's the past secretary of Raichur Obstetric Gynec Society, and as you can see, she loves music and dancing. She also
Very good.
sent me a video, but it was too long, so I didn't share it. So, over to you, Dr. Abhinetri, ma'am. You're muted.
So, namaste, sir. I'm Dr.
Yes,
Abhinetri.
welcome.
I'm bringing greetings from Raichur Obstetric Gynec Society along with Dr. Mangala Gadwal, ma'am. And we deeply respect the consistent efforts you are taking to enlighten us in the field of obstetrics and gynecology. And also good wishes, sir, to you for your upcoming elections.
Thank you.
So
Thank you.
my questions are, who can give consent for MTP, sir?
So if patient is major and patient is mentally sound, then only and only patient can give consent. Because as we go with any other surgery or any other procedure.
So attenders' consent is not required.
Not at all required. If patient is major, mentally sound, then even consent of husband is also not required if patient is married.
Okay. And instead of Form C, can we take the consent in a regular manner, like in a written form or anything like that?
As far as MTP Act is concerned, we have to take consent in Form C. It is very much mandatory. But in Form C, it is simply written that I give my consent to terminate my pregnancy. So it is not informed consent. So in any case of MTP, we will have to go with two consent. One informed consent as we take in any other surgery, and one consent to be taken on Form C. So taken in usual manner, informed consent cannot replace consent to be taken on Form C. So Form C consent is very much mandatory.
So we need to take the consent both on Form C as well as we need to take an informed consent.
Yes.
Okay, sir. And is
But
the
in
consent
this,
of
when we take consent, that is informed consent, signature of witness is not to be taken, because only signature of patient and doctor who is going to offering MTP services.
Okay, sir. And is the consent of spouse required for
No,
MTP?
not required. Not required. If
And
patient
the-
is major, mentally sound, no consent of anybody is required.
Okay. And we routinely advise HIV testing to almost all our obstetric patients. So do we need to take consent for HIV
So
testing?
it is not mandatory, but it is guideline on part of NACO and WHO that you should explain what is the importance of this test of HIV. And before handing over result, and particularly when result is positive, proper counseling is very much required. And if we have taken consent that we had been explained about importance of this test and probable result, then if at all something goes wrong, then we are saved. Because in one of the cases it was happened when she declared that she is HIV positive and that patient committed suicide. So in this situation, police came to doctor that and for statement, etc. So if we have taken consent that it was explained to the patient with its importance and its probable outcome, then we are saved. But of course, it is very rare. It is not mandatory even. It is guideline from NACO and WHO.
And in today's technological advancement era, is video consent valid?
Video consent is very much valid, but it is double-edged sword. I usually go with this sentence because many times if you miss any important point of discussion and recording is there and they will put in court of law that we had been explained this and then after we gave consent, but this important point was not discussed and it is not seen in video. So even if you are going to go for video counseling or video consent, then also you should have paper ready on your table of all the importance point to be discussed as far as your treatment plan or surgery is concerned. So no important point should be missed at the time of video recording or video counseling.
Thank you, sir. Thanks.
Yes, welcome. Yes, Asa madam.
Yes, I just got muted and I was not able to unmute myself. So
Yes.
thank you, sir. And now I would like you to say something about this before we
Yes.
end the session on uniform consents.
Yes,
I've
yes.
also given this link if anybody wants to copy it.
Yes. So on FOXY website, FOXY uniform consents are available. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consents. And it is available on FOXY website. Say, for example, cesarean section, hysterectomy, abdominal, vaginal, endoscopy, termination of pregnancy, medical method, surgical method, consent for blood transfusion, consent for anesthesia, consent at the time of transferring patient to higher center, consent for os tightening, HSG. So we have prepared 30 different consent and it is available on FOXY website. When we were preparing all those consent, we have taken based of famous case of Samira Kohli versus Prabha Manjanda, which I mentioned prior also. And in that very case, Supreme Court has given us all the guidelines. What is the ideal consent in Indian consent? So all those points we have taken into consideration. We have prepared this consent in two parts. Part one is information and part two is undertaking. So as far as information part is concerned, again, it is with almost 8 subheadings. Say, for example, name of procedure. Say, for example, if we are going to take consent for cesarean section. The name of procedure, cesarean section. Then second, meaning. What is the meaning of cesarean section? We have written in a very simple language, to cut open abdomen, to cut open uterus and to deliver baby, that way. Then third is indication. What is the indication for that very surgery? In cesarean section, we have mentioned a full list of indication. But if your patient is having one more indication, then we have put a column also. You can write that indication also. So name, meaning, indication, benefit of consent. If you give consent, then what is the benefit of that very surgery or procedure we are going for? Consequences of refusal, because many times patient is not willing to give consent, and which are the consequences of refusal, that also we have mentioned. Then probable complications of anesthesia, complications of surgery, possibility of infection, possibility of requirement of blood transfusion, and in cesarean section we have mentioned possibility of hysterectomy also we have mentioned. Of course, we have mentioned like this, it is very rare condition where we require this, but it may be required in few of the conditions. So we have prepared that way. Part 2 is undertaking. So whatever we have explained in part 1, sorry, patient will go with undertaking that whatever explained above was we have understood, and then we have given consent. In that undertaking, we have added 2 important paragraphs. In one paragraph, patient will write that in any unanticipated, unprecedented condition, doctor finds that doctor has to go beyond the scope of consent given by me. I give my authority to Mr. or Mrs. So-and-so who is waiting outside operation theater or labor room. Doctor will discuss with them, and if consent is given by them, it is as good as consent given by me. So in certain situation, we have to extend our surgery, or scope of surgery is extended. Then in this situation, we may discuss with that very relative. And one more paragraph we have also added, that in this type of situation, I give, if it is necessary to save my life or it is beneficial for me in future, then I give my consent to doctor to proceed further accordingly and to go beyond the scope of consent given by me. So in this situation, no need to discuss with any relative also. So in that very uniform consent, we have mentioned this. But I would like to mention that also, it is available in Kannada also. All those consent are available in Kannada. So at the time of Kasoga conference at Hubli, we had announced published this book, and that book was available in Kannada. So anybody is interested, then they may contact Kasoga office bearers. It could be available soft copy as well as hard copy also.
Thank you, sir.
Yes.
Now, my request to all the panelists, if any of you have any question, you can ask. Anybody has any question to ask that you think has not been covered so far?
Not
Please
covered,
ask
or
the
any
questions.
extra question related to this concern from my answer or reply rather, if they have any further question. But before that, I would like to request again to endorse my candidature for post of President Foxy election year 2024. In month of May, all the President and Secretary will receive a request from Foxy to nominate candidature. So in month of May, you will have to nominate my candidature. And in month of August, from 1st August to 10 August will be the time for election. So I humbly request to vote for me, but because considering my seniority, my sincerity, my dedicated work in Foxy's for years together, and readily available to be helpful to any of our Foxian friend in any odd situation. Just I mentioned in beginning also why I was late today. So I was there to assist one of our gynecologist friend. So I am always there. So considering all this, please endorse my candidature and appeal for Dr. Asha Jain also. She is going for chairperson, Food, Drugs and Medico-Surgical Equipment Committee. In this, society will vote. So, society A category will give 2 votes and small society 1 vote. So, all the eligible voters are requested to vote for Asha Jain also. And one more request on behalf of Dr. Bharti. Bharti is also going for Perinatology Committee this year. So you will have to nominate Asha Jain and Bharti and myself in month of May. And you will have to go for vote in month of August from 1 to 10 for me and from 15 to 25 for both of them, Asha Jain and Bharti Rajsekhar.
So, sir, thank you, sir. Thank you for making that appeal on my behalf. I request all of you, if anyone has any questions, we can have the questions. Some of our panelists have left because of emergencies, sir. So if all is well and there are no
Any question
questions.
in chat box? So
No,
we can
sir, there
take
is nothing in the chat
okay,
box. We checked.
fine. Otherwise, we can cover that question also.
Yeah, there's nothing in the chat box.
Yes.
So maybe
we
end
have
the session,
completed
sir.
well in time.
Yes.
Sir, we are taking informed consent for every patient.
Yes.
And we are for high risk cases for like preeclampsia and
Yes.
like this,
Yes.
we
Yes.
take video consent also.
Yes.
And thank you, sir, for putting that valid point to keep a paper running all the points we should explain, all the complications. Thank you,
Yes,
sir. Then
yes.
that we will do.
Because I would like to mention one famous case of C. Jaipal Reddy versus Padmini Veluri. It was decided in National Commission. And at the time of deciding this case, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign. It is an important document of your communication. It is important document of your counseling. So whatever you counsel, whatever you are supposed to counsel, I would say rather, each and every point should be mentioned in that consent paper, and then after patient has to sign. So that is why we have come up with all this uniform consent on FOXI website, because we have taken care of each and every important point which are required and which are very much mandatory legally also.
Okay, sir. Thank you, sir.
So one more question, sir.
Yes, welcome.
Sir, in incomplete abortions, in inevitable abortions, we have to fill all the forms like what we do in.
It is complication of pregnancy, so it doesn't come in purview of MTP Act. So no need to for Form C, Form 1, anything. And the same question was raised in one of the RTI in 2012. And in that very RTI, government has very specifically mentioned that it is not at all required to go with any formality of MTP Act.
Okay, sir. Okay, thank
you. And what about when we are prescribing the drugs for MTP, sir? Like if it's not a surgical procedure and we are just giving them.
Madam, if it is not surgical method, it is an accepted method. So you will have to go with all formality of Form C, Form 1, etc. If you go with medical method also. And just I mentioned also 2 consent, one informed consent and one consent on Form C, because in very recent past, I had a phone call from one of our senior Foxian friends, gynecologist. She had given medical method for termination of pregnancy. She had completed all the formalities, Form C, Form 1, etc. And patient just came before 1 week or so with 16 weeks of pregnancy. This pregnancy was terminated in month of October or so. So it was failed MTP. So in this situation, why we are insisting to go for all this formality of consent? In uniform consent by medical method, we have mentioned that point also, that with medical method, it is likely that termination may not occur. And in this situation, you are requested to inform hospital immediately if you do not get your period. So if we have mentioned like this in consent, then it will be very much in our favor if we face any litigation.
Okay, thank you.
Yes.
Any other question?
Usually in MMA, we will call after 15 days, no, madam. Sir?
Yes, in discharge card, you can write like this, follow up after 1 week or follow up after 2 weeks. And
Or
one more line we have.
Three visits first day and after 48 hours after 15.
Yes, yes. And we have to
And
line
that
one
time
more
only
line
we have
also.
to confirm that it is completely expelled
Yes.
or.
And one more line we have also to write that if it is an emergency, then you are requested or you are informed to visit hospital immediately. So if you have mentioned like this, you are safe.
And if the patient comes to government hospital without any male attenders, that time the consent we can take from the patient only.
If patient is major and if it is a case of MTP, then no consent of any other person is required.
No, if she is serious and we have to do her hysterectomy, peripartum hysterectomy.
I mentioned prior also, if it is an emergency, whatever you do to save life of patient is always pardoned in court of law.
But that time we have to inform higher authorities like in MS.
But I am coming to that point also. But burden of proof is always on your shoulder to prove that it was dial emergency and whatever you did was in good faith of patient to save life of patient. In this situation, if you are working in an institution and if institution has routine that in this situation you are supposed to inform head of the unit, head of the department, head of the institution, you have to follow the instruction.
Okay, thank you.
Yes.
So may we end the session now if there
Oh
are
yes,
no
oh
further
yes,
questions?
oh yes, oh yes.
So I thank Patel sir, I thank all the panelists, Dr. Rekha, Dr. Bharti, our respected chief guests, guests of honor, chairpersons, speaker, and Corona Remedies for being our academic partner. I hope the program has been helpful for everyone and it has been value for money. I hope that has happened. Thank you once more. And see you again next week in another webinar.
And suggestions are always welcome to make this type of program in future in a better way. So you are most welcome to have your comments in group or any suggestions in group. You are most welcome. So thank you everybody for everything.
Nilesh?
We can conclude.
Thank you, sir.
Yeah, please conclude the program.
Thank you so much, all respected delegate members and faculty members who have joined this webinar. So now we have successfully completed this webinar and looking forward to with such a beautiful topics and hope this kind of successful webinar will conclude more along with Dr. M.C. Patel sir. So again, thanking you all for giving your valuable time and joining in this webinar. So thank you so much. So with this, I'm ending the session.
Yes, fine.
Thank you.
Thank you. Thank you so much.
Thank you all. Until we meet again next week.
I forgot to thank you, Dr. Rekha.